Hello everyone. The topic for today is Exodontia. Under this, we'll be covering definition of Exodontia, classification of Exodontia and various types of extractions, indications of closed extraction, contraindications of Exodontia, mechanical principles of extraction, delivery of various teeth. So, coming on to the definition of Exodontia, this is the definition given by Geoffrey L. Howe. So, under in this definition, there are four parts. The first one, the painless removal of the whole tooth or tooth root. So, the first part is the painless removal of what? Of whole tooth or tooth root with minimal trauma to the investing tissues. So, while removing the teeth, there should be the minimal trauma to the investing tissues, that is the soft tissues, so that the wound heals uneventfully. So that the wound heals uneventfully. Like there should be minimal trauma so that the wound will heal uneventfully, and no post operative prosthetic problem is created. And no post operative prosthetic problem is created. So, what do you mean by this line? We know after extraction, the patient will be requiring prosthesis like crown, braids, or implants. So the extraction should be such that there is minimal trauma to the investing tissues. What will it do? It will facilitate the wound healing, which will eventually prevent any post-operative problems. So, in this definition, we have to remember four main points: the painless removal of the whole tooth or tooth root with minimal trauma to the investing tissues, so that the wound heals uneventfully and no post-operative prosthetic problem is created. Now, coming on to the classification of Exodontia. Exodontia is broadly classified as intraalveolar, closed or simple extractions, and transalveolar, open or complex or surgical extractions. So, this classification is based on whether we have removed the bone, like the alveolar bone, or not. So, intraalveolar, closed or simple. This is the routinely formed extractions. It is the form of extraction which is this is the most common method. Instrumentation to extract the tooth is confined to the perial space. Like if this is the tooth and this is the bone and this is the perial, so instrumentation is confined only up to the perial space. This is the perial space and this is the bone. So instrumentation is confined only up to the perial space and does not and there is no and the bone is not removed in it. And this type of extraction is also known as forceps extraction, conventional extraction, classical extraction, or traditional extraction. Then comes the transalveolar, open, complex, or surgical extraction. In this, we have to first reflect the mucoperiosteal flap. If this is the tooth, and this is the bone, this is the perial space, and this is the gingiva. So, in this, we have to first reflect this flap, a flap of gingiva. This is to be reflected when we, if this flap is reflected, then the bone is exposed, and then we will remove some part of the bone and we'll deliver the tooth. So, transalveolar, open, complex, or surgical extraction, there is reflection of mucoperiosteal flap and removal of some part of bone. In this extraction, there is high risk of surgical complications, and it is also known as odontectomy, that is the surgical removal of teeth. Now, let's see what is Tobbe's extraction. It is the extraction of multiple mandibular anterior teeth by using elevator between the teeth. Adjacent tooth is taken as fulcrum and not the interdental bone. We'll be studying in the principles of exodontia, like in the lever and fulcrum principle. The interdental bone, the bone which is present between the teeth, this has to be used as a fulcrum, okay, and not the adjacent tooth. Why? Because if we use the adjacent tooth as the fulcrum, it will loosen, and which we do not require. But in Stobbe's extraction, there is the extraction of multiple mandibular anterior teeth. We have to remove multiple mandibular anterior teeth. So we can use the adjacent teeth as fulcrum. So Stobbe's extraction, extraction of multiple mandibular anterior teeth by using elevator between the teeth, and this extraction is done by the elevators, and adjacent tooth is taken as fulcrum. Then comes the rubber band extraction. It is done in patients with bleeding disorders, for example, hemophilia. In this, the rubber band applies tension and leads to necrosis or ischemia of the perial fiber. So, this is done in the patients with bleeding disorders, rubber band extraction. This is a Viva question. So, rubber band applies tension. So, what does this rubber band do? It applies tension and leads to the necrosis of the pedial fibers, and we know that the pedial fibers hold the tooth. So when their necrosis occurs, the tooth will loosen and it will be delivered. Then comes the therapeutic extraction. The extraction of teeth for orthodontic purpose, for example, serial extraction. You will be studying it in ortho. So then comes the balancing extraction, and compensating extraction. In balancing extraction, extraction is done in the same arch to prevent shifting of midline. If this is the maxillary arch and this is the mandibular arch, in balancing extraction, the extraction, if we have extracted a tooth in this quadrant, we will extract the same tooth in the a quadrant adjacent to it to prevent the midline shift. In this is the balancing extraction. And in compensating extraction, it is done in the opposite arch to balance the occlusal relationships. So if we have extracted a tooth in maxillary arch, we will extract the tooth in the mandibular arch so as to balance the occlusal relationships. So the two terms are balancing extraction, extraction done in the same arch to prevent midline shift, and compensating extraction, extraction done in the opposite arch. Then comes the Wilkinson's extraction. In this extraction, what we do, all permanent first molars are extracted in the age between 8.5 to 9.5 years. So what does this do? Since the first molars are more susceptible to caries, this their extraction at the early age will decrease caries and also will decrease crowding, and it will provide the space for erupting third molars. But the disadvantages of this extraction is it will cause deep bite, because the third molar because the molars are not present, there will be deep bite in the interior, and there will be the tipping moment of the premolars and molars. If this is the first molar and this is the second molar, and this is the premolar, when this is extracted, it will tend to occupy the space by tipping. So so these are the disadvantages of Wilkinson's extraction. You will be studying it in detail in orthodontics. Now coming on to the indications of closed extraction, the first one is unrestorable tooth. For example, caries which has been extended to root. In this, the endodontic treatment is not possible, so it is an unrestored tooth in which there is an extensive caries which cannot be restored by endodontic treatment. Number two, vertical tooth fracture. So the tooth can fracture. There can be a vertical fracture or horizontal fracture. So vertical tooth fractures are not restorable, so whenever there occurs a vertical tooth fracture, it has to be extracted. Then horizontal fracture at CEJ. If the fracture occurs at the apical area, it can be restored, or if it occurs somewhere in here, it can be restored. But if the horizontal fracture occurs at CEJ, it cannot be restored, so it is indicated for extraction. Then severe periodontitis, that is grade 3 mobile or sometimes grade 2, because periodontal bone is the only bone that cannot be regenerated. So the bone has lost its support and is mobile and therefore indicated for extraction. Then pericoronitis, it is a very acute condition, that is, it is rapidly spreading. So the most common cause of pericoronitis is the mandibular. It occurs most commonly in the mandibular third molar. What is pericoronitis? Let me give a brief about it. So if this is the mandibular third molar, there is a flap. This is called as operculum, which covers this third molar. So there is a space in between this third molar and this flap in which the food gets entrapped. Because of this food entrapment, there occurs an infection, and this infection leads to inflammation, which is called as pericoronitis. That is the inflammation of the pericoronal flap. Then prosthetic purpose, orthodontic purpose, that is serial extraction. Then impacted tooth, supernumerary tooth, grossly decayed first or second molar, to make room for the third molar, natal and neonatal tooth, over retained deciduous tooth, tooth acting as a foci of infection, that is infective endocarditis or rheumatic fever. If we know a tooth it is having a severe infection and it can lead to infective endocarditis, it has to be removed. Then pathology. If tooth is directly involved by cyst or tumor, as we know about a radicular cyst, if this is the incisor and it has been involved by the radicular cyst or tumor, or if this is the third molar, it has been involved by the ameloblastoma like tumor, then these teeth have to be removed. Then tooth lying in the fracture line. If the tooth which is lying in the fracture line is indicated for extraction if it hampers in achieving the pre-traumatic occlusion, or if the see if this is the mandible and the fracture line is passing through the tooth, so the tooth will be indicated for extraction, or if this tooth is or if the tooth is hampering in achievement of the pre-traumatic occlusion, it is to be extracted, that is it is indicated for extraction. Then the next indication is bilateral sagittal split osteotomy. It is an orthognathic procedure in which the bone cuts are given through the third molar region of the mandible. If this is the mandible, yahan se the cuts are given, so the third molar is to be extracted 3 months prior to this surgical procedure. Then teeth within line of fire. For example, in a carcinoma patient, radiotherapy is indicated. Now he has a tooth which needs to be extracted. That extraction should be done before the radiotherapy is initiated. Why? Because radiotherapy has various adverse effects on our body, on the oral mucosa, on the bones. So if we extract the tooth after during the radiotherapy, it can lead to osteoradionecrosis. That is there is hypocellularity, hypovascularity, and hypoxic condition. So the teeth should be extracted before the initiation of the radiotherapy to prevent such condition. So this is the teeth within line of fire. Then patient's own will. Even if the tooth can be restored and the patient does not want it to be restored, patient wants it to be extracted, then the tooth will be indicated for extraction, because that is the patient's will. Coming on to the contraindications of exodontia, contraindications can be absolute or relative. In absolute contraindications, there is central hemangioma. Central hemangioma, in patients with central hemangioma, there can be uncontrolled bleeding and AV malformation. So, absolute contraindications of the exodontia include central hemangioma and AV malformations or aneurysms. Then, relative contraindications. In this, when we have to take precautions, or we have to delay the extraction till the suitable conditions are available for extraction. This is the relative contraindications. Relative contraindications can be local or systemic. In local, for example, acute cellulitis, acute pericoronitis, or necrotizing ulcerative gingivitis, we can prescribe antibiotics, or we have to wait for some days till the acute condition subsides, after which we can perform the extraction. So this is in relative contraindication, local category. Then systemic contraindications. Uncontrolled diabetes mellitus. Diabetes should be under control. If we perform extraction on a patient without checking his blood sugar, then there can be complications such as dry socket, poor wound healing, or uncontrolled bleeding. So we have to rule out uncontrolled diabetes before performing extraction. Then hypertension, blood pressure should be under control if the extraction is to be carried out. Then bleeding disorders. These patients are usually on anticoagulants. So we have to check the INR values, international normalized ratio. These values should be in the normal range. If they are not in the normal range, then we will have to alter the dosage of the anticoagulants, or we may ask the patient to stop taking anticoagulants for few days. Then liver disorders, cerebrovascular accidents, patients on long-term steroid therapy, then teeth that have undergone radiotherapy within 6 months, and within 6 months of myocardial infarction.